it's not perhaps so much about whether these treatments work or which treatment works better. It becomes in many ways a strategic decision about how you're going to get access to all of these treatments for any individual patient.
That's exactly right.
Which then brings up yet another question. If it's this difficult to select a sequence, what about just giving a couple of them at the same time?
Right. Combination therapy.
Combination
Right.
therapy.
Right.
What do we know about that
Yeah.
at this point?
So, well, if we know little about sequencing, we know nada about combination therapy. We have some data. I mean, you did a beautiful study of a phase 2 of mTOR plus Bev in pancreatic neuroendocrine tumors. Now, everolimus and bevacizumab is generally an easier drug to add to drug therapies, and it did improve the response rates, as you know well, although it had some more sort of side effect appropriate problems, hypertension and things like that, with a little benefit, at least in the phase 2, to show an incremental improvement. But the question really becomes, in our patients that can live for many years, should we be using combination therapies that undoubtedly usually will add more side effects and toxicities? And I think we don't have data to really know for sure if that's the right answer, but we can sort of take a play out of the breast cancer book, I think, to say that their disease is similar to ours, that is sort of estrogen receptor positive or metastatic breast cancer, where unquestionably combination therapy is not helpful. And I think that's something to learn from. So it's a great question. There are certainly some combinations one can think of that may be a little bit better tolerated, but in general, I think we have to be extremely careful in our patients to avoid unnecessary side effects. So I would favor more sequential therapy as opposed to combination.
So in favor, at least for the targeted therapies, thinking about sequential. When we are talking about chemotherapy, for chemotherapy combinations, there is perhaps some data that giving cytotoxic chemotherapy in combination might be more effective than single agent therapy. How do you think about that?
Well, at least for temozolomide-based regimens, we can use it in combination with capecitabine or as a single agent. And with streptozocin, I mean, that has been shown to have increased benefit when used with either a fluoropyrimidine
right.
or an anthracycline. So I think for chemotherapy, it's a little bit different. I do agree with Diane in the sense that, we have a population of patients who live for extended periods of time, and unless we feel that the combination is going to result in an improved survival benefit over one followed by another, then we have to really question if that's the right approach, especially given the toxicities associated with the treatments.
So another question that comes up and sometimes is forgotten with somatostatin analogs. Sometimes we don't even think that much about adding another treatment to the somatostatin analog. James, in your practice, how do you think about combining somatostatin analogs with other types of treatments, or even in fact for some of your studies? Yeah. Radiant-2 looked at everolimus with octreotide, Radiant-4 did not.
Yeah, I think that's definitely an interesting question, and I think it depends on what the clinical situation is. If this is a patient with carcinoid syndrome or functional tumor, clearly you need SSA for the, essentially the syndrome control. And when that's not enough, adding another agent may be very well appropriate. But in a non-functional patient, I think there isn't the data yet to support combination with SSA is better than single agent. For example, in the cooperative 2 study that you did, we saw that although there may be a little bit benefit in terms of response rate, but the progression-free survival of adding pasireotide to everolimus, there weren't any PFS benefit. So that's a instance where you may argue that adding the SSA may have increased some of the hyperglycemia without really bringing much in return.
So then for a functional patient or a patient who is having symptoms of hormone hypersecretion, pretty much a no-brainer, you have to keep the SSA going. But for those patients who are not secreting hormones, it becomes a much more challenging issue.
Yeah. I think
about whether you keep it going or whether you just move on to the next one and stop.
I think the SSA beyond progression is still a clinical trial question. Many people believe that we need the information for.
Exactly. So this has been a great discussion. We've covered a lot of information regarding the management of various types of neuroendocrine tumors. Before we end this discussion, I'd like to get final thoughts from each of our panelists. Thank you all, by the way, for terrific discussion and contributions. Dr. Eads, any parting thoughts?
I just think that that we just are very fortunate as a group of neuroendocrine physicians to have had such a wealth of positive trials over the last couple of years. And I think that the opportunity to be able to integrate things that are not yet available to us, such as PRRT, is very exciting. It obviously leads to a lot of unanswered questions, but I feel very grateful that we now have the options that we do available for both pancreatic neuroendocrine patients and carcinoid patients.
Thank you. Dr. Liu, parting thoughts?
Well, I just want to stress the idea that having a multidisciplinary team is so very important. I am very pleased and honored to be among you very famous medical oncologists. However, there are other doctors who are very important as well: gastroenterologists, endocrinologists, interventional radiologists, pathologists, who are a very important part of the team. Because sometimes taking care of these neuroendocrine patients, it's not really what to do. The art of neuroendocrine is sometimes when to do it. And we all come in with our different biases from our different experiences and training. And so making sure that we have an open conversation about the patient, really trying to find the very best timing, sequencing, ordering of our therapies, I think is critically important.
Thank you. Dr. Reidy-Lagunes.
I couldn't agree with you more. I mean, I think that it is certainly a privilege to take care of patients with this terrible disease. I think that one of the biggest struggles for our patients and for us, quite frankly, is the heterogeneity of the disease, that it is so, every patient is different. And so my job is to define that plan for that patient. And, you know, fortunately or unfortunately, there's a lot of patients that say, but my friend X, who also has neuroendocrine, got this, and why don't I go to surgery? And you know, Dr. So-and-so said we all should go to surgery, and that couldn't be farther, sorry, Eric, but there are doctors out there that say, we gotta go to surgery, and you know, and so I actually feel like it's my duty and obligation to spend a lot of time with my patient to define why I think their disease needs to have the following treatment, and that's my job. And I think that, you know, thank heavens for Dr. Kulke and Dr. Yao, you really did change the face of the way that we care for this disease. Our patients have a cancer that's pretty terrible, and they deserve the evidence and the trials, and just because we have rare diseases doesn't mean we can't conduct these studies. So thankfully they're happening, and it's sort of a new era, and I think it's been really remarkable. I mean, we have a tumor, unlike other cancers, that has had an explosion of therapies. Like, you don't see that in other diseases that we take care of. So there's good things. Obviously there's a lot more work to be done, but there's good stuff going on.
So Dr. Yao, a lot of progress, but I think a few more trials that still need to be done, no?
Yeah, I think there's definitely still a need to further improve. I guess my one take-home message from this is we are moving to the age of essentially evidence-based therapy, and there's room still for some further improvements. Like it's not uncommon from a referral center that we would see patients with pulmonary carcinoid, atypical carcinoid of the lung, with a Ki-67 in the 5-10% range, coming to our office having had a lot of etoposide and platinum with their alopecia and neuropathy and absolutely no evidence of benefit. I think we need to kind of move away from that, and with the newer treatment available, I think we can really improve the quality of life in these patients and offer more effective therapy.
On behalf of our panel, we thank you for joining us.